Hello everyone, now in this video I will be discussing about the thyroid gland, the anatomy, functions and synthesis of thyroid hormones and hyperthyroidism. So let's start. So what is thyroid gland? Thyroid gland is a butterfly shaped gland which is an endocrine gland, sits and wraps around the trachea. It produces two main hormones, that is T3 and T4. The thyroid gland has two lobes, right lobe and left lobe. Anteriorly, thyroid gland are joined by a structure called isthmus, and posteriorly, thyroid gland circles the trachea, but it will not connect the trachea. From the dorsal view, we can see four parathyroid glands. So, developmentally, thyroid isthmus can give rise to a structure called pyramidal lobe, which extends upwards. It is common in 55% of people, and it is a result of persistent remittent of thyroglossal duct. Here we can see the hyoid bone and laryngeal prominence and cricothyroid ligament, right lobe, left lobe, isthmus and trachea. So coming to the arterial supply of the thyroid gland. We have a branch of external carotid artery, that is superior thyroid artery, and we have a branch of subclavian artery, and that is inferior thyroid artery, thyrocervical trunk and brachiocephalic artery. So coming to the nerve supply, thyroid glands are innervated by sympathetic nerves from the cervical ganglion. These nerves does not control the secretion of thyroid hormones. We have a vagus nerve and a branch of superior laryngeal nerve, and we have a right recurrent laryngeal nerve and left recurrent laryngeal nerve, and thyroid gland is also innervated by the parasympathetic nerves. So coming to the venous drainage of the thyroid gland, we have superior thyroid vein and middle thyroid vein, which drains into the inferior jugular vein, and this drains into the brachiocephalic vein, which in turn drains into the superior vena cava. So this is the venous drainage. And coming to the lymphatic drainage, we have pretracheal lymph nodes, paratracheal lymph nodes and submandibular lymph nodes and submental lymph nodes, and superior cervical lymph nodes, and here inferior cervical lymph nodes. So coming to the functions of thyroid gland, it has a role in growth and it has a role in development. It stimulates the heart rate and heart contraction, and it degrades the cholesterol and triglycerides, and it increases the vitamin requirements. Now let's discuss about the synthesis of the thyroid hormones and what structures are involved and how the hormones are formed. So here the three main structures involved are hypothalamus, anterior pituitary gland and thyroid gland. So coming to the hypothalamus. So in the hypothalamus, what happens is paraventricular nucleus. These cells secretes the thyrotropin releasing hormone in the hypothalamus. Okay, this thyrotropin releasing hormone gets into the anterior pituitary gland, and this stimulates the anterior pituitary gland cells called thyrotropes. When the thyrotropes are stimulated by the thyrotrope releasing hormone, what happens is thyroid stimulating hormone is released from the anterior pituitary gland. So this TSH, which is released from the anterior pituitary gland, circulates in the blood and enters the thyroid gland. What happens is when the TSH enters the thyroid gland, it stimulates the thyroid gland to secrete the thyroid hormones T3 and T4. Now let's look at the thyroid gland. We will zoom in the thyroid gland. So these are the follicles, the round structures of the follicles, and this middle area is colloid, and the small cells are follicular cells which are thyrocytes, and these are the blood. So when the TSH, which is released from the anterior pituitary, binds to the thyrofollicular cells in the thyroid gland, which stimulates the thyroid gland to produce the thyroid hormones. Okay. So now let's discuss in detail about the thyroid hormone synthesis, how they are formed. So when the TSH, which is released from the anterior pituitary gland, binds to the receptors on the follicular cells. Okay. When the TSH binds on the receptors, this releases the thyroglobin, which is an important protein. This thyroglobin is released. Okay. So next, this TSH helps in production of thyroglobin. It not only helps in production of thyroglobin, it also helps in the reuptake of iodide from our diet into the blood. Okay. Then this iodide, which is absorbed from our diet, and the sodium travels to the colloid region through a transporter called pendrin. Then it forms iodide. The iodide gets converted into the iodine in presence of thyroid peroxidase enzyme, and this process is known as iodide oxidation. Here we have two important products for the thyroid hormone synthesis, that is thyroglobulin and iodine. So thyroglobulin contains the amino acids, that is tyrosine, and one iodine comes and binds to the tyrosine, and two iodine comes and bind to the tyrosine, which produces the diiodotyrosine and monoiodotyrosine. So here we have diiodotyrosine and monoiodotyrosine, 2 DIT and 1 MT, which produces a T3, that is triiodotyrine, and we have 2 DIT, that is diiodotyrosine. We have 2 DIT, 2 DIT, which produces the T4. So in the follicular cells, the thyroglobulin forms a T3 and T4 through a help of enzymes called proteolytic enzyme, that is protease. So the T3 and T4 which are formed act on the target tissue. How they act is, the majority of the T3 and T4 travels through the blood by binding to a protein called thyroxine binding globulin, which is TBG. So coming to the hyperthyroidism. So what is hyperthyroidism? It is a condition in which there is a excess production of thyroid hormones, and we have another condition, that is thyrotoxicosis, which is the overproduction of thyroid hormones. As we discussed before, from the hypothalamus, TRH hormone is released into the anterior pituitary. In the anterior pituitary, thyroid stimulating hormone is released, and it travels to the thyroid gland, and it produces T3 and T4, as we discussed. Follicular cells, from the follicular cells thyroglobin is released, and iodine containing hormones, and these bind to the plasma proteins in the blood. So coming to the actions of T3. So it speeds up the cell's BMR, and it increases the cardiac output and stimulates the bone reabsorption and activates the sympathetic nervous systems. So the causes of hyperthyroidism, or what are the causes of hyperthyroidism? We have Graves' disease, toxic nodular goiter, and hyperfunctioning thyroid adenoma. And anytime thyroid gets damaged and inflamed, and iodo-based syndrome, and neonatal hyperthyroidism, and secondary causes. Now let's discuss the causes in detail. So coming to the Graves' disease, which is an autoimmune disorder, the B cells produces the antibodies against the thyroid proteins, and the thyroid stimulating IgS binds to the TSH receptors and stimulates to produce more thyroid hormone, which also causes the thyroid gland enlargement. And the next cause is toxic nodular goiter. the follicles start generating the lots of thyroid hormone and hyperfunctioning thyroid adenoma, benign tumor making excess thyroid hormone. And anytime thyroid gets damaged or inflamed, large release of preformed thyroid hormones. Coming to the Jod-Basedow syndrome, it is an iodine-induced thyrotoxicosis. It develops after the iodine deficient person gets heavy dose of iodine. Okay. So coming to the neonatal hyperthyroidism. In this condition, what happens is during the pregnancy, the antibodies cross the placenta into the fetus, and the newborn infant suffers from Graves' disease. A plasmapheresis removes the maternal TSHR antibodies and cures the infant's disease. So coming to the secondary cause. When a tumor in anterior pituitary secretes a lot of TSH in response to thyroid secretion increases, and the symptoms include weight loss, increased BMR and heat intolerance, rapid heart rate, sweating, hyperactivity, anxiety and insomnia, and bulging of eyes, and risk of congestive heart failure and osteoporosis. So coming to the diagnosis. So when a patient experiences these symptoms, how to diagnose? You have to do a blood test, measuring the blood levels of TSH, T3, T4. So in hyperthyroidism, the TSH will be low and the T3 and T4 will be high. And radioactive iodine uptake test and thyroid scan. Coming to the treatment, treatments are based upon the cause. We can give beta blockers to treat the immediate symptoms, and anti-thyroid drugs, and radioiodine therapy and surgery in extreme cases.